We're here at the CROI, and we're doing a kind of a little bit of an overview of the DAD study. And we have three wonderful women here who are going to kind of give us an overview and some specifics of pieces of the DAD study. So we have Lena William from the DADS cohort, DAD, and we're hoping that you can give us kind of an overview and a sense of what is the study, what does it do, who are the participants, how long, and so forth.
Well, I'm very happy to be here. So the DAD study was founded back in 1999 based on an initiative of the EMA. They wanted to look at long-term adverse effect of antiretroviral drugs in a large heterogeneous cohort study, such as the DAD study. And so during the past 17 years that the study has existed, the study has done just that, namely looking into various associations between different antiretroviral drugs and centrally validated clinical endpoints, including cardiovascular disease, renal impairment, liver impairment, cancer, mortality, dyslipidemia, and so on. And so the DAD study is a very large heterogeneous study. It's based on almost 50,000 HIV-positive individuals from 11 different cohorts. So kind of a very broad study to investigate potential adverse effects in. So the DAD study has also looked into getting a better understanding on the comorbidities that we know are seen at a higher rate in the HIV-positive community as compared to the general HIV-negative population, trying to get a better understanding of the factors that are driving these comorbidities in addition to potential adverse drug effects. So to be more specific or to provide more detail, the DAD study throughout the years of its existence have looked into drug associations, and they've found that cumulative use of certain protease inhibitors and current use of abacamir is associated with a higher risk of myocardial infarction. They've also shown that cumulative use of tenofovir, boosted atazanavir and boosted lopinavir, is associated with a higher incidence of developing chronic kidney disease. This is completely irrespective of any pre-existing renal impairment. In the study, we've also showed the use of certain protease inhibitors is associated with increased incidence of cancers, most notably anal cancer, and that use of D drugs is associated with higher rates of clinically defined liver failure and hepatocellular carcinoma. So very clinically well-defined endpoints. I think it's also notably, it's important to notify that the DAD study has also shown a lack of an association with certain drugs. So for instance, we haven't shown any association between use of efavirenz and death from suicide. So I think that's also important. So the overall aim, you may say, of the DAD study is to help the clinical decision making, to help personalize the choices for the clinician and individualize treatment and monitoring based on the individual risk profiles.
And the important thing here is that we do know that we're learning that people are going on through, because the treatment is better to be on treatment or not. We want to know in that context, okay, what are the risks though? We know the benefits, so this is the risks.
Exactly.
And it seems like, I mean, out of hand, it seems like the benefits will certainly outweigh the risks. But the risks are there, so we have to know what are the risks. We've defined them.
And I think it's just a matter of tailoring the treatment better to each individual person's risks, so that if you have someone on, for say, a high risk of renal impairment, they have diabetes, they have hypertension, familial disposition to renal disease, let's choose another regimen that's more renal friendly than one that we know that have nephrotoxic potential. And I think that also goes for the other drugs that we've shown a potential adverse effect with prolonged exposure to.
A number of years back, we were doing a lot of work with David Back, was talking about this individualized therapy, dose therapy. And because we realized that, obviously an 80-year-old woman might not have to take, ostensibly might not have to take the same amount of drug as a very physically active 200-pound athlete.
Sure.
And so we always were trying to get at that, maybe the protease inhibitors and so forth. So did you look at that at all?
We're not really in a position that we can look at dose response.
Just do whatever the dose was agreed upon,
Yeah.
prescribed.
So I don't think that's the force of the DAD study. We need to let somebody else look
Do
at that.
that.
But that's obviously
worthy.
also something
Yeah,
that's
worthy,
important to look into, whether you can dose adjust. And there are for certain drugs where you need to dose adjust according to liver impairment or renal impairment. So it's something to be aware of as a clinician, that's for sure.
Right. We definitely want to be on a treatment that's effective, but we also don't want to be taking more of the drug to make it more deleterious. So,
Sure.
in the long run.
Yeah.
So, you've given a pretty good background. So a lot of people in this study, 50,000?
Yeah.
That's huge. Now, where are they from?
So
what is the
there are
population?
11 different participating cohorts, mostly from Europe, but we also have data from the US, from the CPCRA cohort. So it's a kind of a wide population, but mostly driven by male men who have sex with men population.
Now this is Europe, and the United States is, the first world. So
And we also have data from Australia.
Oh, you do?
Yeah,
Okay.
yeah.
So what would you say, should there be something similar to this to evaluate? Because the populations in, say, sub-Saharan Africa will be different. Do you think they should be looking at the same study?
Well,
or
absolutely.
something?
I mean, we can't say anything about comorbidities in a population for which we don't have the data.
Right.
So I think if they have the resources, it would be absolutely very relevant to see what are the levels of comorbidities in such a population, and are we seeing the same sort of associations?
Same correlation, yeah.
It's not given that it's the same. They have a different genetic background that may mean that they react differently to different exposure to drugs. But simply from the data we have now, I don't think we can say anything on the safe side, but it would absolutely be relevant to also have data from an African continent, absolutely. Yeah.
Great. Now, you brought your own poster, your own work to the
Yeah.
CROI, and can tell us about that.
Sure. So that's very exciting news, looking at the associations between various measures of immune suppression and chronic kidney disease. And so basically, I think we've established now that chronic kidney disease is much more prevalent in the HIV-positive community as compared to the general HIV-negative population. I also think that we know by now, based on the START study and other studies, that in individuals with a preserved immune function, chronic kidney disease is quite rare. But based on previous studies, both from the DAD study and other studies, we've shown that immune suppression is an independent predictor of getting chronic kidney disease. So what we did in this analysis was that we looked at various different measures of immune suppression and looked whether we could find the best predictor of chronic kidney disease among these different measures of immune suppression, because nobody has really looked into the nature, actually, of this association. Everybody has noted that there is an association, but not quite in what way it works.
Right, right.
So based on this very large data, we followed individuals that had available data on renal function markers and immune suppression markers. And we looked at a wide range of different markers and see which one predicted development of chronic kidney disease best.
Can you mention some of those markers?
Absolutely. So they were the NAD CD4 cell count, the CD4 cell count at study initiation, the percentage of follow-up spent with a low CD4 cell count, CD4 cell count recovery. So a very different way of looking at immune suppression to kind of see which one is the best predictor. And so we did a series of different analyses, also taking into account other factors for chronic kidney disease. And here we found that the percentage of time that you spend with a low CD4 cell count is the best predictor of developing chronic kidney disease when you're talking about immune suppression.
When the time you spent low.
Exactly.
Really, because some people bounce
Exactly.
down and then, so it makes sense.
It makes sense, and I think this also supports this quite rigorous approach to antiretroviral treatment. So everybody should be on treatment in order to maintain a high immune function, to prevent developing chronic kidney disease.
Because I think we had that study that demonstrated that obviously being off treatment is not a good idea.
For a number of reasons.
Some people, but there was a time where people, I'm just over it. I want to take the summer off, and so it wouldn't be a good idea to do that without evaluating whether that's possible.
I mean, judging from this data, it's not necessarily how low you go, but the time spent with a
Is it collective,
low
or
CD4
is it? Do you think it's collective? If people take every summer off from drugs?
I mean, we haven't looked at that specifically, but I mean, it is the time spent with a low CD. Yeah, right. It is. So I think that's an important measure. And we also looked at kind of trying to put this in relation to other renal risk factors. Mm-hmm. And here we found that it's basically those that don't have any other risk factors, so no hypertension, no hepatitis C, not at a very advanced age, those are actually the ones that the immune suppression means most. So if you already have these other comorbid factors, to have yet another one doesn't mean as much. But if you're a relatively healthy individual, that's really something that becomes important for your risk, for your renal impairment.
Now, I didn't talk with you about this in advance, but is there some way that someone that's really interested in digging into this study that can understand it, in a more of a lay terminology? Is there someone that's done a synopsis of it somewhere for the lay public?
For renal impairment?
No, just the whole study.
For the DAD study?
Yeah.
I mean, there's a quite, do you mean for community-based?
Yeah.
I think that we have quite a nice different annual report coming out of the DAD study where you can get more insight into the different initiatives that have been taken and are currently going on as well.
Okay, maybe we'll be able to put that up on the screen somewhere.
Sure.
Right up on that.
That
Great.
would be interesting.
Well, I really appreciate your taking the time, and there's two other wonderful women here that are going to be talking on their presentation and also kind of wrap up as well. So I do appreciate you taking the time.
Well, my pleasure. Can I just finish off by
Yeah,
saying
yeah.
that in DAD we believe that it's crucial that we continue to have a pharmacovigilance monitoring of adverse effects of antiretroviral drugs over time, especially since the cohort of HIV-positive individuals is aging. And you're seeing more comorbidities, more polypharmacy, and also new drugs continue to be licensing where we don't have any long-time follow-up.
Yeah.
So I mean, it remains important that we continue to collect this data, even though we already now know a lot of adverse drug effects.
This study
There's
should go
still-
on.
exactly.
It should go on and on and on.
Yeah.
Because it's a cohort it's fabulous. It's
Well,
just
thank
it's the thing that we really need. This is the thing that is most important to the people. How can I stay healthy? How can I know how to stay healthy?
Exactly.
And this is answering the question right there. Thank you so much.
Well, thank you.
We're continuing the presentation that we have from the DADE study, and Camilla Hattelberg, who's from Copenhagen, Denmark, will do a presentation. You have your poster here today, and we wanted you to do a little bit of an explanation of what it is in simple talk.
Yes, thank you. So I'm going to present our study on differences in predictors for ischemic and hemorrhagic strokes in HIV-positive individuals. So no previous studies have investigated whether there are differences in risk factors for hemorrhagic and ischemic strokes in HIV-positive individuals. So our objective was to investigate this question in the setting of the large heterogeneous DAD cohort. We included a little bit more than 43,000 participants between 1999 and 2014. Then we used separate union multivariable Poisson regression models to identify association between demographic, cardiovascular disease-related and HIV-related risk factors and both types of stroke. Risk factors were then formally tested for whether their association with the two types of stroke differed significantly. So, our findings included analysis on 83 hemorrhagic and 296 ischemic strokes. This figure shows you our main findings, the adjusted relative rates for risk factors and stroke. So our main results showed that the strongest common risk factors for both types of strokes were age per 5 years older, CD4 count less than 200, and an elevated blood pressure. However, the association between elevated blood pressure and hemorrhagic stroke appears somewhat slightly stronger than for ischemic strokes. Conversely, ischemic strokes appeared to be more strongly associated with traditional cardiovascular disease risk factors such as male gender, previous cardiovascular disease, smoking, diabetes, dyslipidemia, and also low BMI. Ischemic strokes also appeared more strongly associated with HIV-related risk factors such as ejection drug use and previous AIDS. Further, when tested formally in another model, no risk factors differed significantly in their association with risk for either type of stroke other than male gender, which was a stronger predictor for ischemic stroke, and injection drug use, which was a stronger predictor for hemorrhagic strokes. However, the lack of more positive findings may be due to a small number of hemorrhagic strokes. In conclusion, our findings are mostly similar to those reported in the general population and emphasize the need for preventive measures and screening. Further research is needed into the use of stratified stroke risk predictors to provide more precise risk estimation. Thank you.
So a lot of this, the work that's being done, it's flushed out what we really suspected, and it puts it into a context of answers to the questions through science. So so would you think that doctors are doing a good job of risks assessment up to this point, or do you think that there's a little bit more work to do?
Yes, we still know that HIV-positive individuals have a high cardiovascular disease risk profile. This study doesn't investigate in particular how well physicians do. It only tries to identify which risk factors are typical for both types of D-stroke. But knowing more about that would definitely help in improved prevention.
So doctors be more aware about the risks, so then
yes.
they can move forward and do a better job of assessment. So the presentation that you're going to be doing the posters here at the CROI.
Yes.
This CROI. Is this your first CROI?
No, it's my second CROI.
Second CROI.
Yeah.
So how do you, just to get a sense of your feeling about it, is this impressive, or is this, because you've been to one other CROI, is this something that you find very helpful?
To be here at the
conference?
conference?
Be at the CROI,
yes, definitely. It's, of course, the most important scientific conference in the HIV field. So it is, I'm highly appreciated to be here and to have an abstract accepted. That's, of course, a main goal of the year, actually. So I really appreciate that.
I guess people, they schedule their work and we've got to get it ready for this CROI or something like that, because there is the other conferences throughout the year, but this is kind of like the preeminent conference.
This is the main one, the most important one, yeah, definitely.
Did you find, what other advantages did you find in your experience at the CROI to meeting with other colleagues of similar work? Do you look at other posters? Do you talk to your colleagues? That to me is what I think a lot of the people will get out of it, like yourself, who will learn to collaborate with others maybe, or to learn from them and their work too.
That is definitely one of the most important things while being at a conference, to talk to other people in your field and try maybe to have new contacts and collaborators, and of course to try to dig deeper and have further knowledge, and especially your own field, but also in other fields of research.
Because if you want to know about the CROI, you can go online, you can watch videos and so forth. But actually to contact or talk to a person at a poster, like they will with you and you with others, is probably the key experience that I guess you'd get out of this.
Yeah, it is, because you are able to ask specific questions and really interact, yes.
Well, I really appreciate you spending the time with us, and I
you.
really wish you a great conference experience.
Thank you so much.
Thank you. We're here at the CROI. We're wrapping up a series with 3 wonderful women from the DAD study. We're here with Caroline Sabin from UCL in London. You're a statistician, so I think we want to kind of get the wrap-up here at this point of the work that you brought to the conference, and also a sense of the statistics.
So I guess you probably already know, and Lena's already mentioned, that some years ago the DAD study presented some results showing that people living with HIV who were receiving the drug abacavir had a very increased risk of having heart attacks. A couple of years ago, we then showed that association was still there and still present, even though there was actually quite a lot of evidence that the clinicians treating the patients are actively being very careful about their prescribing with abacavir, and they're selectively choosing people who it would be better not to prescribe abacavir to, and are suggesting that those people receive other drugs. But despite that, we still saw that association. But one of the things we'd never looked at is whether people who'd already had a heart attack, who were then either still on abacavir and stayed on it after they'd had their heart attack, or who then newly started the drug afterwards, whether that group of people were also at an increased risk of having a second or a third heart attack. So the research that we've presented at this conference is looking at just that. It's taking the group of people within the DAD study, where we've already seen them have a heart attack over the study period, and then we looked at their treatment patterns and looked to see whether people either stayed on abacavir, or whether, if they weren't on it at the time, if they then subsequently started it. And then we looked to see if those people had an increased risk of having a second or a third heart attack. And we found actually that they did seem to have this increased risk. So it almost seemed to be similar to having the association with having a first heart attack during the study. But what we also noticed was that the people who either stayed on abacavir or started it tended to be the people who were being followed up in the early years of the study, when perhaps we weren't really aware of the true risks associated with the drug, and we hadn't published our findings. And when we took into account the fact that those people had been under follow-up for longer, so of course they would have had more an opportunity to have a second or a third heart attack, we saw that the effect there with the association with abacavir actually dropped. Now, that to us, it's still a little bit tricky to tease out the effects because, of course, the two effects themselves, so the calendar year effect and the receipt of abacavir, are so tightly connected to each other. It's very hard to really tease the two effects apart. But certainly it looks as if that maybe that in people who've already had a heart attack, there may not be such a strong association with receipt of abacavir. But we would clearly still recommend that as a high-risk group, people who've already had one heart attack are obviously clearly at very high risk of having another one. And so our recommendation would be that abacavir is still avoided in that group unless there really is no other alternative option for them. So that's the summary of the poster that I'm presenting here this year.
Really is good information because I think a very large number of people who are living with the threat and the family history of cardiovascular disease are certainly interested in such a finding.
Yeah.
But the one thing that I want to make clear, I think our population and our viewership is very diverse. So we have some doctors, we have patients and so forth. But I think it is important for people to understand the difference between a study and a cohort. Cohort is really you're just following natural history or natural course of activity of a person, as opposed to a study where you prescribe a certain this or that or the other.
So a cohort study is what we refer to as an observational study. Essentially what we do is we just follow patients in their routine clinical setting. There isn't any intervention other than what the doctors and the patients agree on themselves. And we just monitor and look at what happens to people over time. And that is a good study design. It gives you very good quality information, but of course there are problems associated with that because we can never really tease out why does one person get abacavir whereas another person
because it was not a head-to-head thing or anything like that.
No, so I mean the difference would be then with a randomized trial where you would have a direct head-to-head comparison and you would randomize patients to receive either abacavir or an alternative regime. And that's a much, much stronger study design. But of course, it's very difficult to conduct.
This is a starting point.
Yes.
I would say a starting point.
Well, I mean, it's actually quite tricky with the abacavir and the Heart Disease Association because, of course, it is a starting point. It shows us an association. We don't quite know why we see it. We don't really know if it's true, although the evidence really is increasing would support it as a real association. But you're right, there's still sort of biases and problems with those associations there. The problem is, of course, we'd like to do, well, I mean, if you wanted to really answer the question properly, you would want to do a randomized trial, but it's very difficult now to do a randomized trial where you randomize one group of people to abacavir and
you run into ethical problems.
You can run into huge ethical problems now, not least as well the size of population that you would need.
You're already talking with the DAD is 50,000 people.
Yeah.
So
well, I mean,
this is the biggest problem with I think cohorts is that it's a lot of money invested in it.
Well, there's a lot of money, but to do a trial of the equivalent size would be, it would be prohibitive. You wouldn't be able to do it, but also the ethical issues would be far too great. And it would be very difficult now, I think, with the evidence out there, to actually, for a clinician or even for a patient to actually be willing to be randomized to abacavir if they already know that they have a high cardiovascular risk. So we're in a very difficult situation where the study design that you really want to do, you just can't.
You know, that's interesting because this has evolved. I mean, at one time we were doing treatment against no treatment.
Yes,
and it's a way back because, of course, we didn't know the treatment was really good or was it bad. But now that we know that treatment is good, now we just say, okay, this is the benchmark. Now we have to go do better than that. So every drug has to come out to be better than the last one or have an advantage. So it's very difficult when you think about designing trials and designing trials for new drugs that are then going to be for the general population, but really are more suited for the people who are in deep salvage or in a salvage scenario. So it's a challenge. As a statistician, you probably go through all kinds of
Well,
hair pulling.
our challenges, yes, lots of hair pulling, but our challenges really are to try to understand the reasons why different people get different treatments,
Right.
and what has led them to receive a certain course of treatment at the moment. And some of the patients that we follow, of course, have been treated since 1990, 1991, so they've had a very long and interesting course of treatment and may have started and stopped many different regimes over those years. Others, of course, may have been newly diagnosed, gone straight in with a treatment that we would consider, a contemporary treatment regime today. So they're very, very different groups of people, and trying to tease those effects out and the effects of the type of person, the characteristics, the behavioural and the lifestyle factors, which of course all play a major role in determining your risk of cardiovascular disease. That's very tricky, and so we have a team of statisticians who spend most of our lives trying to work out the best way to do that.
Well, I'm appreciative so much of the DAD study, and especially from you three for coming today, to yourself specifically and the other two the women that really brought to light a lot of the little nuances and the interesting facts and pieces of what they bring to the trial, the cohort, because it's much larger than you three. It's huge numbers
Most
of people that are
certainly,
involved.
most
But it's great to have a
Yeah.
piece of it here today.
Great, thank you very much.
Thank you so much.